let's see. I'll start from the top. So our first question was, with recent MRIs, the transrectal ultrasound still done? Yes. Um, so MRI is great, and more for prostate cancer, it is becoming almost standard of care to get prostate MRIs. However, insurance is not up to date on that, and so many insurance companies will require you to have a measurement of your prostate by transrectal ultrasound in order for insurance to pay for it. Even though you may already have an MRI, insurance-wise, to cover the procedure, you will still need a transrectal ultrasound. It's very silly. But clinically, is it necessary? Not necessarily. Our next question is Aquablation similar to laser in principle, removing prostate material from inside of the prostate? Yeah, so TURP, Aquablation, and the laser enucleation of the prostate, all three are resective procedures. We're actually removing tissue rather than just stenting things open or making the channel bigger. We're actually removing tissue to make the channel bigger, and that's why you get more durability. So in the sense that they're all resective procedures, they're the same. However, the laser nucleation removes more tissue, but not everyone needs that much tissue to be removed to have good outcomes. And the downside of removing all that tissue is you get higher rates of incontinence and ejaculatory problems. Next question was, with PAE, prostatic artery embolization, when will maximum improvement be achieved? We typically say that it takes about 4 to 8 weeks to have peak improvement after the PAE. And so that's why we see people at the 4 month mark afterwards with the peeing Euroflow test to see objectively if the flow has gotten better and to reassess symptoms. Okay, and then the next question was, can PAE be repeated if the amount of change doesn't adequately address the symptoms? So from a technical standpoint, for sure, PAE can be repeated. Although I would be hesitant. Let's say you had your PAE 4 months ago and you're seeing me in clinic and you say, hey doc, I haven't noticed a single change. While we can repeat that procedure, I don't know if that would be the best option for you. At that point, we can talk about repeat minimally invasive procedures versus maybe just going forward with aquablation or a resective procedure. And then with PAE, what is the long-term follow-up and follow-up testing? So the way that our practice is run, we work very closely with our interventional radiologists, and just like any procedure, it's about experience. And so our interventional radiologists specialize in urology. They do 6 of the PAE procedures in a day or more. It takes them 30 minutes to 45 minutes. If you go to a less um, experienced proceduralist, it can take 2 to 3 hours. And because we're so well integrated and they're part of our system, the follow-up is very seamless where after your PA procedure, they'll have a 4 month follow-up with us. For any BPH procedure that you have, we'll be following you with repeat urine flow tests to make sure your flow is sustained. We'll be checking in with urinary symptoms. Later on, if you have any concerns about decreased flow, we can always repeat the cystoscopy and the ultrasound at that point, especially if you had like a minimally invasive procedure where we're not where the retreatment rates are higher. Someone said, is this for scheduling call? I'm not too sure what you mean by that. So if you can re-type the question in another way, then I can try to answer it. And next question was, does the size of the penis matter in any of these procedures? The answer is no. The length of the penis or girth of the penis doesn't necessarily matter. What does matter is the size of the urethra, like to be able to accommodate our tools, our scopes. Um, and so typically urethras are pretty pliable, so they can accommodate our scopes. If they don't, we can passively try to stretch them out so that our scopes can fit, but rarely is it an issue where we can't do the procedure because the urethra can't accommodate our scopes. Do you use nitrous with cystoscopy and can you drive afterwards? So I would say majority of the time, um, we're able to do, depending on what location you're at, we offer cystoscopies and transrectal ultrasounds just under local anesthesia with numbing jelly in your penis, and you can drive yourself. However, if you're being seen at our Alexandria clinic, all of our procedures are being done right across the bridge in National Harbor, uh, and that's still over there. You can do it just with local anesthesia, the numbing jelly, and drive yourself. But if you've had the cystoscopy in the past, or you know that you don't tolerate that sort of discomfort well, or you just want to have a more relaxing experience, the nitrous is available at our surgery center. If you do have nitrous, you cannot drive yourself. Um, the next comment was uh, concern about PAE spreading prostate cancer. And so there's been plenty of research with PAE, and as far as spreading prostate cancer, there isn't uh, really any substantial evidence to show that. So I would not have that deter people from doing that. You know, what can happen sometimes is we get a PSA on everyone during this BPH workup. And even though the PSA is low, even though the transrectal ultrasound or MRI may be negative, it's still possible to have cancer. And if you do PAE on someone who has cancer, it doesn't change their cancer at all. It's just maybe it's picked up later on. And so it does not spread cancer. Can many of these procedures also help improve ED in addition to urination? It can. So, I don't ever advertise. I will say, doing a BPH procedure, I never say your ED will get better, but in some patients it may. But that is not the selling point of the procedure. If it happens, it's just a fortuitous uh, plus to doing the procedure. And the next question was about medications. Taking finasteride now, does it worsen prostate cancer? So, taking finasteride, the research is not as clear. So it does not increase the chances of prostate cancer. However, it may increase when the prostate cancer is detected. It may increase the grade. It may be a higher grade prostate cancer that is diagnosed. Um, Finasteride, when you take it, it can shrink the prostate and it artificially decreases your PSA by 50%. So anyone who's on finasteride, if you have a PSA that's 3, in actuality, if you stop taking your finasteride, you can adjust that to being closer to 6. And so, that 4 cutoff that we use for concern about prostate cancer, we have to take that into consideration when someone is on finasteride. But for prostate cancer workup, no one thing is used to determine your prostate cancer risk. We combine prostate MRI, the velocity of how quickly your PSA is rising, something called a PSA density meaning per volume is the PSA more dense. So if you had a huge prostate and your PSA was 6 versus an itty bitty prostate and your PSA is 6, I'm more concerned that the person with the itty bitty prostate with the PSA 6 has prostate cancer because their PSA density is higher. Because normal prostate tissue makes PSA, but prostate cancer cells make PSA at a higher rate. Um, Okay, the next question is, doesn't aquablation spread cancer? So the answer is no. There is no evidence showing that TURP or aquablation or any BPH procedure spreads cancer. If you already have cancer there, okay, not often, it's not uncommon that when you do a resective procedure, because even for aquablation, after we ablate the tissue with water, we do get some focal cautery to stop any bleeding. And we also remove a little bit of tissue and we make sure that tissue is benign. So some people already have prostate cancer, and when we resect tissue, we're able to see that they have prostate cancer. But typically, the way we diagnose prostate cancer is by doing a prostate biopsy of the peripheral zone. But let's say, we resect tissue and, patients ask me, hey, doc, aren't you concerned that you're seeding this prostate cancer into the bladder? And theoretically, that does make a lot of sense. But in actuality, when we look at the research, that's not how prostate cancer spreads. Prostate cancer affects glandular tissue. And one, your bladder itself has an impermeable layer called the urothelium that it's not affected by that. So the answer is it does not spread prostate cancer. When you do aquablation, can you send the removed tissues for cancer? Exactly. You can send it for cancer screening, but the second part of the question was, then can you eliminate a biopsy? And no. So if your prostate's like this, your urethra is right here, we're removing the prostate tissue around the urethra, but we leave a rim of peripheral tissue called the peripheral zone, and that's mostly where prostate tissue is located. So even after you have a positive tissue sampling from an aquablation or a TURP or even a HOLEP, then we need to biopsy you appropriately because the peripheral zone may have more aggressive cancer than what's in your transitional zone. And so we have to be very thorough about that. Okay, next question is cystoscopy done prior to scheduling a PAE? Yes. So the standard workup for our BPH, because we offer so many different procedures, we need to tailor it to your body and your preferences. So everyone gets the same workup. Uh, you have the Eurocuff test to measure your flow and your bladder pressures to see if you have a functional blockage problem. You get the cystoscopy to look at the shape of your prostate, if it's just your lateral lobes or if you have that median lobe, and also to look inside the bladder to see your bladder health, to see if there's already bladder damage. And then lastly is the transrectal ultrasound to get an accurate size. So after you do those 3 tests, then we can recommend PAE and discuss whether you be a good candidate for that. And the thing, and I didn't make this point clear before. You can have 2 identical people, identical size, shape of their prostates, bladder health, Eurocuff tests. But if one person wants a minimally invasive procedure and the other person wants a resective procedure, they're gonna get different treatments. So it's not just the objective measures we have. A lot of it, we're gonna be working together as a team to decide what's the best treatment. And at the end of the day, once you know the risks and benefits, whatever choice we make together, that is the correct choice. Okay, our next question is, how painful is a cystoscopy? Uh, it really depends. Everyone's tolerance is a little bit different. Uh, I have some men who they're like, "Oh, that was it," and other men who are really uncomfortable during the procedure. And for those people, we in the future we may have them do it under nitrous or do other relaxation techniques for their pelvis to make it easier. Well, with all my cystoscopies, I tell patients to, take nice, slow, deep breaths, to wiggle their toes, even to whistle or purse their lips, because by doing so, it relaxes the pelvis. And I also make it clear that patients shouldn't tighten up their abs because it clamps down on the urethra, and that trying to advance the scope through a clamped down urethra, that causes pain. And so it can be really subjective. How do we discontinue Proscar and Eroxetrol in conjunction with PAE or Aqua or ITIN? Okay, so for Aqua, any BPH med you're on, you stop it the next day. I don't need you to continue that. For PAE, um, ideally, depending on how severe your symptoms are, I think everyone should get a trial of discontinuing their medications. Uh, I would first stop the finasteride, and then maybe after another month stop the alfuzosin, tamsulosin, uroxetrol, because the finasteride takes about 6 months to go peak effect. It also takes about 6 months to lose its effect, whereas the other alpha blockers work immediately within a couple of days. And so PAE for the first month, you may not notice any improvement. So I would not start peeling back medications until you're 4 to 8 weeks through it. And then for ITIND, um, yeah, would consider stopping the alpha blockers and finasteride uh, like a week or two afterwards when all the inflammation and swelling has gone down. And then if you feel more uncomfortable, then you may have to restart an alpha blocker. But hopefully at that point, um, you'll be able to have more benefit than you did before the procedure. In a perfect world, the whole point of doing a minimally invasive procedure would be to get you off meds so you're not on one daily. And so if we don't accomplish that goal and that was one of your priorities, then we can talk about doing a more definitive procedure, a resective procedure. And then will you send us a copy of the presentation? Yeah, I'll find a way to disseminate this information. Okay, may I ask how many aquablations I've done personally? So in our practice, I'll start with the most senior, Dr. Inder Singh. He's done, I think he's approaching like 900. He started back in 2018. Uh, John Klein. So there's four aquablation specialists in our practice. Um, it's Dr. Singh, Dr. John Klein, Dr. Shanmar Mahdi, and myself, Dr. Lim. Uh, in seniority, Dr. Singh is definitely the most senior. I'm definitely the most junior. Under my belt, I probably have around 100. The difference between my training and my senior partners is when I trained at Georgetown, Georgetown was learning how to do this aqua ablation, and then so I was already trained in residency to do this procedure, and so when I came and practice here, I was already up and running. Does small 0.5 centimeter kidney stone condition impact prostate treatment options? Kidney stones are completely separate. It does not preclude you from doing any prostate treatments. Um, so it should be unrelated. And let's see. When we take tamsulosin and finasteride to control BPH and prostate cancer, what are the side effects to male sexual activities or performance? Okay, so the reason why um, this is a shift in a paradigm shift on how we treat BPH. So older generations of urologists, back when there was only the roto-rooter to really treat BPH, more people were on medications. So everyone was on tamsulosin and finasteride, and it wasn't until you were truly unhappy that your symptoms were not treated well that urologist may have offered you a TURP or a resective procedure. But with this boom in innovation and all of these different minimally invasive options, I would say the paradigm shift has been we need to focus on preserving bladder health. So, also, medications are not without side effects. Tamsulosin, the most common side effect is dizziness, lightheadedness, and especially in our elderly patients, more senior patients, that dizziness, it only takes one fall to hit your head to break your hip that is life changing. Also, there's retrograde ejaculation issues with finasteride. There are issues with erectile dysfunction, breast tenderness. It affects hormones, so that's why it shrinks your prostate. The other benefit other than shrinking your prostate is that it can help with hair growth. But you know, I would in my personal practice, unless you truly do not want a procedure, unless you are really have other medical issues precluding you from doing a procedure, I do not like having people stay on medications, especially if you're early on the BPH spectrum, age spectrum, and you're starting medications at 50, like you're going to be on this for the rest of your life, and eventually it may stop working. Like we can do a procedure and get you off of a medication or two by actually fixing the problem. Um, and I think that's all I had for here. So I've been talking for a bit. I really appreciate everyone taking the time this evening to listen and to get more education about BPH. BPH is an area that I'm really passionate about, and at Potomac Urology, we have such a comprehensive, standardized pathway to treat patients that you will be in good hands. I can promise you that. Okay, let's see. One last question. What is the PSA level that needs the practice? Um, PSA, we just screen to make sure there's no concern for prostate cancer. We always, if there is concern for prostate cancer, we address that first, and then once we make sure the MRI is fine or the prostate biopsy is fine, then we go back to focusing on BPH. Okay, everyone. I really appreciate you guys taking the time. If there are any questions, please contact our offices. Hopefully, this gives you some more information and motivates you guys to, if you are on the fence about doing a procedure, that you don't have to continue living the way that you're living. There are very safe options. Even our more maximally invasive procedures like aquablation are still very safe. It's a same-day procedure. Um, so it was great chatting with all of you. One last plug that I will say is if you guys, we do have a YouTube channel that goes over aquablation more in depth, and all of our BPH procedure, really all of our procedures and other information about urology. So you can find us at the Potomac Urology Center. And if you subscribe, you'll be updated with all our latest news and everything. Okay, have a good night.